Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome again to another episode of our show. Today, bringing you another really fascinating guest discussing a really fascinating topic that is involved in creating a better tomorrow for so many people out there. Today, we have the honor of being joined by Dr. Sharon Inouye, who is the director of the Aging Brain Center at the Hinda and Arthur Marcus Institute for Aging Research, Hebrew Senior Life in Boston, Massachusetts. Dr. Inouye has her medical degree from University of California, San Francisco, her master's in public health from Yale, and currently holds the Milton and Shirley F. Levy Family Chair and is a professor of medicine at Harvard Medical School, Beth Israel Deaconess Medical Center. And her research focuses on delirium and functional decline in hospitalized older patients, which has resulted in hundreds of peer-reviewed articles in the literature to date. Dr. Inouye is the principal investigator of the Successful Aging After Elective Surgery, or SAGES study, which is an $11 million program that was focused on delirium, funded by the NIA, with the purpose of examining the interface of delirium and dementia, whether delirium alters the course of dementia, and ultimately how delirium leads to longstanding cognitive impairment and pathologic changes in the brain. Dr. Inouye also developed and validated the confusion assessment method, which is the most widely used instrument for identification of delirium. She also developed the Hospital Elder Life Program, or HELP, which is a multi-component intervention strategy designed to prevent delirium by targeting a range of risk factors. Dr. Inouye has been awarded many of the highest accolades in her field, including being elected to the Institute of Medicine of the National Academies. A lot of really interesting topics to get in today with her. All that being said, Dr. Sharon Inouye, welcome to our show, and thanks so much for joining us today.
Ira, I'm so delighted to be here and to be back with you again. I so enjoyed our first podcast, and I just want to say and thank you for the wide-ranging exploration into aging and into healthful living more generally. Thank you.
Well, I appreciate that, and I appreciate you being here because you are, you are at the epicenter of such an important area of the pathobiology of the human brain and related changes in aging, and it's just such an important theme. And once again, thank you for taking the time. Sharon, where I would like to start is basically where we did last time, and to sort of bring this audience up to speed a bit. In a paper that you published several years ago entitled "Joining Forces Against Delirium: From Organ System Care to Whole Human Care," you talk about your first encounters with delirium, specifically talking about your father in a hospital that entered a state of delirium, and you ran into this situation where sort of no one knew what was going on, and you were sort of, it was sort of pushed to the side, like, yeah, this happens, but we don't really deal with it, and it's sort of the side issue of everything else that was going on. Talk a little bit about that era and a little bit of your sort of first exposure to this, because this really sets everything in motion that we'll be discussing later on.
Yeah, absolutely. And one of the things I've been very struck by as you interview various people, Ira, is as they share their personal stories and you see the origins of their passion and interest. It's so meaningful. And so, yes, love to share my story. And I really got interested in the area of delirium directly out of my clinical work. Even before I was a geriatrician, I started as a general internist, actually out of VA hospital in Connecticut. And what I found there in my very first rotation as a medical attending, which is the very first time, after I've completed all my training, that I am responsible for a group of 35 to 40 patients. They are my responsibility. The buck stops here. And I have a team of residents and interns and students who report up to me. And so you feel tremendously responsible. And I found during that month of intensive inpatient service that there were 6 patients who were all older who developed this acute confusional state. We didn't even call it delirium in those days. And I didn't know what was going on. I didn't know what this condition was. I hadn't learned about it in medical school or in my training. And I turned to my colleagues, my, respected senior physicians and chief of service. And I said, what is it about these older patients who come into the hospital and get confused? And they all said similar versions of the same thing, Ira, that just happens in older people. We just see it, Sharon, all the time. Don't worry about it. It's kind of expected. And so different versions, they said it different ways, right? But it was the same message that this just happens. And so, I kind of accepted it during that month. I had to kind of get through the month. And then afterwards, it just didn't sit well with me because those 6 patients didn't do well, Ira. They went to the intensive care unit. 2 of them ended up dying. 2 of them went to nursing home. And these were all patients who came in okay, cognitively okay. And so again, with wanting to learn, I decided to pull all their charts, review all their charts, and figure out if there was anything I could pinpoint from reviewing the charts that might have set off this sort of cascade towards confusion and bad outcomes. And I identified, potential medications like opioids or antihistamines that might have contributed. These patients were immobilized. Many of them got infections. And so I started seeing these common themes, and I brought my summary up to the chief of service, who said to me very patiently, "Oh, Sharon, this is very interesting. Why don't you create a lecture for the house staff on prudent management of medications in older adults?" And he thought that would solve the problem being me, not the delirium. So actually, that's what started me on my path. I realized, wow, this is an area that we need to pay attention to. So that's really how it started. That's what made me realize I had to get trained in research. So I went back and got research training. And then I went back and got geriatrics training. So I kind of did everything a little backwards. But then I was a full-fledged geriatrician and a trained clinical researcher, and I embarked on my career. Now, flash forward about 10 years to where I've completed now, some of these seminal studies that you've mentioned, developing the CAM, and testing the hospital elder life program. And I received the dreaded phone call that my father, who's a physician and my hero, and the reason I'm in medicine at all, to follow in his footsteps, has just collapsed at the hospital, emergency admission to a medical center, a very respected medical center in California, and where we lived and where I grew up. And he was had a massive myocardial infarction, which is a heart attack, and he was getting prepped for cardiac surgery. And so, of course, I was actually in the midst of an NIH study section, and I had to quickly book a flight and fly out to California. And so I'm at his bedside. He's just emerged from cardiac surgery. And my father is, completely confused and hallucinating. And he did recognize me, but, was saying things that didn't really make sense. And he wasn't doing well physically. He wouldn't eat, a lot of other things that accompany a delirium. And so here I was, a world's expert in delirium, and I could not prevent it or even help in my own father. And my father went into acute renal failure he was a diabetic lifelong, and went into acute renal failure from the contrast dye that was used for the cardiac catheterization prior to the surgery. And so he was in acute renal failure requiring dialysis. He was on many different medications that were started, obviously, because he had a big surgical incision from heart surgery. So he was in pain. He was on opioids. He wasn't sleeping. So they started him on some sleeping meds. He was not able to eat and was very nauseated. So he wasn't on anti-nausea meds. He was being seen by the gastroenterology team. He developed an infection in his arm. He was being seen by the infectious disease team, the renal team, the cardiac surgery team. You get the picture. And there weren't enough hours in a day that I could track down every team and communicate with them every day. And the other thing is, my father was this tiny Japanese man who only weighed, I don't know, 130 pounds soaking wet. And they were dosing him with doses of meds that, even in his healthiest state, he couldn't tolerate. And and he also ended up losing his hearing from an antibiotic during that admission. So it was I just realized how helpless I was in that setting. And I was trying to educate all of the many different healthcare teams coming in. And in that article you mentioned, I put in actual quotes that I was hearing from the healthcare professionals who honestly didn't realize the seriousness of delirium and that what they were doing was contributing to it. And I realized that we needed to change healthcare systems. And so that is what then really embarked me on the next stage of my career to try to focus more on developing these more holistic healthcare systems for older adults.
And as you're mentioning and taking us through the story, this prompts you to do these and several of the different studies and the protocols, the assessment methodologies mentioned in the intro. It leads to the paper on HELP, or the Hospital Elder Life Program, New England Journal of Medicine, the multi-component intervention to prevent delirium in hospitalized older patients. And you outline, several baskets of risk factors for potential interventions. And you spoke about some of these here. I mean, things like, as you're mentioning, the hearing impairment, in your father's case, caused by an ototoxic antibiotic or something like that, sleep deprivation, immobility, dehydration, the lack of just interaction, so many things here. Talk a little bit about, because this is really, I refer to sort of combinatorial approaches to disease and these different conditions, but talk a little bit here about sort of how you triaged all of these and came up with the sort of the 6 core components of HELP.
Yeah, that's a really important and perceptive question. It turns out in older adults, many, many different conditions, the common sort of conditions that we're trained on as geriatricians, and I'm a specialist in geriatric medicine. So things like falls, things like delirium, things like pressure ulcers, things like frailty, these are all what we call multifactorial conditions. So exactly what you identified, that there are many different risk factors that feed into a person developing these conditions. And so it's a combination of how vulnerable the person is, either through age or other chronic illnesses, or multiple medications, or social isolation, or vision and hearing impairment. And then on top of that, there are what we call precipitating insults or noxious factors. And we know during hospitalization, you are just bombarded with new medications, new procedures, new things happening to you, being immobilized in bed, getting, urinary catheters inserted, all kinds of things happen to you in the hospital that are necessary for your care and yet can be associated with complications. And so what we decided to do in HELP, I had done a series of studies before I developed the HELP program, looking at what are the risk factors for delirium, what predisposes people to developing a delirium. And we identified, about 6 or 7 really critical things, which you've named many of, Ira, and they included comorbidity, which means having a lot of, pre-existing conditions, vision and hearing impairment, sleep deprivation, immobilization, dehydration, lack of adequate nutrition, and then polypharmacy, or getting multiple medications, particularly ones that can lead to confusion during hospitalization. And then also baseline cognitive impairment, which is a big, obviously, even mild degrees of cognitive impairment can predispose someone to develop a delirium. And then on top of that, we did a second study to look at what were the precipitating factors during hospitalization. And the leading precipitants were number 1, 2, and 3 were medications. Yes, and then infections, either being the reason you're brought to the hospital or that you develop during hospitalization, any need for a major medical or surgical procedure, sleep deprivation, and immobilization being some of those acute things during hospital stay. And so we designed HELP. I selected those 6 areas. It was like a narrowed down list, but it was things that I really thought we could make a difference for during hospitalization. So they were cognitive impairment through orientation strategies and therapeutic activities, really like fun and socializing activities we could do at the bedside with patients 3 times a day to keep them engaged, keep them oriented, attending to nutrition and hydration, attending to mobility. And so trying to get people up and walking 3 times a day. Ideally, if they can't walk, then exercising 3 times a day. We provided vision and hearing adaptations for vision and hearing impairment, and we taught staff how to communicate with patients that have vision and hearing impairment. We also provided the staff with simple adaptive devices they could use for amplification, for instance, for hearing impairment. And then we taught the staff about being very attentive to limiting the use of sleep medications. We made a non-pharmacologic sleep protocol available. That's a fancy way to say a glass of warm milk or herbal tea, relaxation music, and a massage.
Nice.
And that sleep protocol was in great demand, not only from the patients, but from the staff as well. Particularly the on-call medical staff were lining up for their massages. So, so those are the strategies, really, Ira, for the Hospital Elder Life program. And we have demonstrated now in over 25 clinical trials that if those strategies are done and they're done well and consistently, that we can prevent delirium in nearly half of the cases in the hospital. And this has also been extrapolated now even into the ICU setting, into the nursing home setting, into other settings, and has shown to be very effective.
It's outstanding. That's really outstanding. And yeah, that close to 50% success is just, yeah, it's such a major impact you're having in the area. So I'm glad you mentioned that as well. Sharon, since we chatted last, you've done quite a bit of publishing on themes related to delirium, and I'd like to go into a couple of these papers with you. If you could just take us, and I think that sort of the first set of themes, you published in Brain Communications in 2022, June 2022, just recently. And this was a paper entitled "The Structural Integrity of the Anterior Mid-Cingulate Cortex Contributes to Resilience to Delirium in Superagers." And then there was another paper as well. This was on biomarkers, patterns and persistence of perioperative plasma and cerebrospinal fluid neuroinflammatory protein biomarkers after elective orthopedic surgery using somatostatin. Sorry about that. Long titles, but at the end of the day, both sort of biomarkers, so biologic and some biophysical components yielding either increased or resistance or resilience to delirium. Talk a little bit about what you're finding here, because I think this is a sort of a whole new landscape that you weren't focused on when we last talked, but really studying, what makes somebody either resistant or more likely to have these things.
Again, I are so perceptive of you. We're really in the last 5 years, my team, and I have to acknowledge this incredible team of co-investigators that I work with on the SAGES study, the Successful Aging After Elective Surgery study, which both of these studies you mentioned are outputs from just an incredible team. And we are trying to, our sort of conceptual paradigm is that delirium, being an acute confusional state, allows us almost a platform for investigating how the brain fails in this acute circumstance, of major surgery, following major surgery. And if we could pick some clues out of that, can we then, and knowing again, as we do, that delirium is preventable in up to half of cases, is that an opportunity for us to actually prevent long-term cognitive decline and dementia?
Right.
And as you well know, treating Alzheimer's disease, treating dementia, and finding ways to really make an effective difference has been so elusive, despite, now billions of dollars going into the field. And I and many others feel that delirium is like low-hanging fruit, right? We already know it can be prevented. So let's figure out, if we can prevent delirium, what can we do in the long term? And so we're trying to, these two studies that you mentioned are particularly on that pathway of us trying to understand what creates brain resilience and what is that linkage between delirium and dementia. If we can really establish it, then, really if you wanted in real life to establish a linkage, you need to do a 20-year study.
Yeah.
And that's just not realistic. And so if we can convincingly demonstrate those linkages now with the data we have, and then work to prevent the delirium, which we know how to do already, And then we can more quickly see, right, if we can impact dementia. And so that's what we're trying to do, is create these convincing links. So let me start with that super agers study. So we have a group out of the Mass General Hospital. They have conducted just a brilliant study within SAGES. So we had volunteers in SAGES, about between 100 or 110 patients out of 420 in our SAGES 2. This is our elective surgery cohort, the second one we've enrolled. Who are all undergoing elective hip or knee replacement. And 420 were enrolled, and about 100 of them agreed to undergo MRI, functional MRI study. They all had detailed neurocognitive testing that were interpreted by a neuropsychologist, Dr. Bonnie Wong. And Dr. Wong and Dr. Torotoglu identified that there were super agers in our subgroup of SAGES participant. Super agers, and this is actually something that's described already in the aging field, is people who are aging in a youthful fashion. So they're in their 70s and 80s or even older, and yet retaining the memory function. So this is really specific to memory, the memory function of a 40 or 50-year-old. And so they basically have phenomenal memories, probably much better than mine. And so there is this group of super agers in our cohort, and they were very excited to identify this subgroup. They were definitely there. And what they did is they definitely had a lower risk of delirium, and they had, better on their functional MRI studies, as you said, they were able to localize this anterior mid-cingulate area as possibly being a very important area for brain resilience. And so this is so important, because that's an area that's actually been identified also in the Alzheimer's world as a very important area that is being targeted for treatments and for seeing what can be done to preserve the functioning in that domain. And so we were very excited, first of all, to see this overlap in the fields, and also to be able to do now a series of studies on the super agers that are present in our SAGES cohort, because we also want to follow up with biomarker studies, et cetera. And so then to turn to your question about biomarkers, so here again, but now focusing on the entire SAGES cohort, and we have 560 in our SAGES 1 and 420 in our SAGES 2. So really close to 1,000 patients between our two cohorts. And what we're trying to do here in a series of studies, Ira, and you may have seen, perhaps scores of articles that if you search on the names of Drs. Ed Marcantonio, Drs. Tuvia Lieberman, and Dr. Fa Vasanilashorn, they are the champions in this area. And what we're trying to look at is whether neuroinflammation might be the secret that's leading to both delirium, and then if there's sustained neuroinflammation, does that lead to long-term cognitive decline following delirium? Because we have in previous studies in SAGES shown that there is a proportion of patients following delirium who develop a trajectory of long-term cognitive decline that's quite accelerated after surgery. And so we want to understand why that's happening, who is at risk for that, and is it truly inflammation in the brain? Because we were sampling in these early studies only the blood, but in SAGES 2, we are now sampling CSF, cerebrospinal fluid. And so we're trying to look at the correlations. These studies are fairly early on, and we're trying to see if we can identify a neuroinflammation profile. And then we want to see if that correlates with what's seen in Alzheimer's disease, because it's already been well described in the Alzheimer's field that neuroinflammation plays a critical role. Another area where we're focusing on biomarkers is biomarkers of neurodegeneration and neuronal injury, because that's a really fast evolving field. And there are many sensitive biomarkers that we can now identify in the blood that indicate that brain damage has occurred. And we believe, our hypothesis is, those patients at risk of long-term cognitive decline and dementia following a delirium are those who somehow either the neuroinflammation or maybe there's vascular insufficiency as a result of the surgery can go on to have neuronal degeneration. And we're trying to pick that up with these ultrasensitive biomarkers. And so those are some of the studies, Ira, that you've seen. Again, these are all preliminary. We are trying to select and test which biomarkers are going to work the best. We're trying to develop the story and develop the hypotheses. But I do feel this is an extremely important area, because it can only be through understanding, right, that pathophysiology that we're going to be able to develop effective treatments ultimately.
Absolutely. Sharon, while we're on the theme of inflammation or neuroinflammation in this case, could you say just a couple words, because you've also published this paper on delirium after COVID-19 vaccinations in nursing home patients, a case series. And not to make light of anything, but after all my COVID vaccines, I had the worst possible headaches, and I had these really vivid dreams. The type of dreams you wake up from and you're like, oh, it takes you about 5 minutes to realize, I wasn't mountain climbing with Ned Beatty and all that type of stuff. But anyway, not to make light of it, but say just a couple words about some of what why you looked at this particular sort of cohort and just about this study.
Yeah, so that is so interesting. And yeah, I just want to start out by saying COVID-19 itself has myriad effects on the brain, as you well know. And we are, that is going to be a very ripe area for investigation to understand, and is going to give us a lot of clues to brain functioning, I'm sure, as we move forward.
Yep.
In terms of the vaccines itself, and I have to just express that the vaccines, they have saved us, right?
Yeah.
If people will get them, we could get this pandemic completely under control.
I'm with you.
It's a complete miracle of modern medicine that we were able to develop those vaccines so quickly and so effectively. And they are potent vaccines, no question, and have many different types of reactions and many ways that they prime the immune system.
Yep.
And is why they are so effective, right?
Yep.
But the vaccines themselves, as many of us know, can lead to very vigorous autoimmune type reactions. when my children, my husband, my relatives come to me and saying, "Oh my goodness, I'm so sick following that vaccine." And I said, "That's great. It means it's working. It's doing what it should be doing. Call me in 2 days if you're not better."
Yeah.
So I didn't hear back from any of them. So
There you go.
yeah, I assume they were all better. But you're right. All the muscle aches and the headaches and the bad dreams and the total body fatigue. And
I'm fine with all that except the headaches. I mean, I hate headaches, but sorry, I
yeah,
didn't.
yeah,
Anyway.
headaches are bad. So there's no question that the vaccines were potent, and that's how they worked, and they clearly revved up the immune system in all possible ways, and that's a good thing for us. So why we decided to do that study, it's really because we started to see cases of delirium in the nursing home population following COVID vaccine. So no surprise, right? If you have a frail 85, 88-year-old getting a vaccine and then resulting in the fever and the total body aches and the headaches, and you could see a delirium.
Yep.
And so we wanted to report on that, mainly so long-term care providers could be aware, could put into place a little bit of extra assistance if it was needed, just to really call it out. We did not at all want to discourage anyone from getting the vaccine. All of the patients recovered completely within a week. We had follow-up with them all. So it was all very short-lived, but we just wanted to call that out because, again, a vulnerable patient getting something that can cause a fever, can cause not feeling well. Yep. We wanted to make sure nursing homes were aware, that family members were aware, but again, only so for those 2 or 3 days that the reaction might last, that they would be vigilant, wouldn't send patients off to the hospital, right? Like, because that really wasn't necessary, but just to be vigilant, be aware, and, put things into place and know that this would happen, because it really hadn't been described before that study.
Yeah, no, that's, I said that one popped out at me. I was like, well, Sharon really is looking at all angles of this. No, I think it's important, and I appreciate you sharing.
Yeah, and I want to acknowledge my team with Wing Yun Mac and Ken Bookfar at the New Jewish Home in New York, who are really the ones who conducted that study and had the idea. So it was so brilliant, and we just encourage them to do it because it hadn't been described before, and we needed to give a heads up. But again, not to discourage anyone from getting the vaccine. Yeah,
completely with you on that. No, absolutely. Sharon, a couple weeks ago, you published Nature Review Neurology, October 2022. Again, the interrelationship between delirium and dementia, the importance of delirium prevention. And this is another paper I think just everyone listening should take a look at, because I think it's your most recent and sort of the interconnection and between why we should be we deal with delirium to help dementia and vice versa. And it just got me thinking because, again, in this paper you describe, right, on one hand, we have the evil of dementia, chronic progressive loss of this cognitive ability. Here we have delirium, this acute confusion. And it got me thinking, are there sort of other forms of delirium or sort of maybe slow, let's say less acute, sort of in between, and the reason I'm thinking about this now, we were mentioning before about hearing loss and sort of in the HELP protocol, and I was a couple, last year I talked to Dr. Charlotte Yeh at the AARP, and she had recently published on this interesting study about hearing aids and dementia, and sort of if this dramatic impact that if we just help a little, and that sounded a little bit more. Wait a second, if it's some acute hearing loss, sounds like it pops into the delirium basket first and then attacks and dementia, sort of flows in that direction. And I'm just wondering, sort of, are there, just like in coma scores and sort of all these different gradations of different diseases that we talk about, are there different sort of gradations of delirium that may be sort of studied or intervened with differently?
Yeah. It's totally a great question. And Ira, frankly, one that we don't have full understanding of yet. But let me tell you what we do know. So we do know, and I believe that there is this continuum, as you say. There's a continuum between delirium and dementia, but it's not really shown. We don't have the complete evidence yet. But we do know that there are what we call subsyndromal delirium or partial forms of delirium. And so where people don't ever get like a full-blown case, and yet they have some of the symptoms, or let's say they're recovering from a full-blown delirium episode.
Okay.
And I will even have, some people can have severe episodes like in the ICU. So it's been described with COVID as well, and families will contact me 2 or 3 or 4 months later and say, listen, they're not like they were in the hospital, but they're not back to normal, and they still can't read the newspaper, which they were an avid, they did the New York Times crossword puzzle every day, and now, they can't even start it, and there's definitely these subsyndromal forms that we see that can take a long time to resolve. The other thing, and I think this gets more at your question about dementia, I think there are reversible forms of dementia. It wouldn't be, necessarily an Alzheimer's type dementia, but I can tell you the scenario that I've seen pretty commonly in my own dementia practice. I can't tell you the number of times I saw this where a family member would bring in their loved one and say, listen, I can't manage them anymore at home. They have to go to a nursing home, like immediately. And could you please evaluate and help us, get that process started? And I will evaluate and find like 11 things that I think are contributing to cognitive impairment in this person before me. Typically like 5 of them are medications. There may be, I had some patients where there was a significant alcohol problem, and hearing could be thrown in there, and social isolation. And so I will say, I'm going to help you with this. Yes, we can make a long-term plan, but would you be willing to work with me closely on tapering off some of these medications, on tapering off the alcohol, on getting hearing aids, and then let's see where we stand. Let's give it 3 months, and then let's see where we stand. And in the meantime, I'm going to help you get home services or a day program in place, and let's see what we can accomplish. And I can't tell you, Ira, how many times the person miraculously was so much better once we got them off all these meds into a daily program on a routine, buffed up their nutrition, got them off alcohol, got them, with physical therapy, walking every day and exercising. And I can't tell you how many patients I kept out of nursing homes. So is that a reversible dementia? Is that a partial delirium on top of a dementia, right? I don't know what we call it exactly, but clearly there were reversible things, and the when they were brought to me, the family said they've been declining over years, right? Like it wasn't like a 3-day thing. It was progressively over years. And now they just couldn't take it anymore, or at least over the past year.
Gotcha.
But then we were able to turn it around in weeks to months. And different versions of the same story. And many people went on to decline over years, but we kept them out, for quite a while and kept them in good condition, at least for several years before ultimately the natural progression of the Alzheimer's disease caught up.
Mm-hmm.
So that's a very long-winded way, Ira, to
No,
say.
I enjoyed that.
I think there is a continuum, and I think there are many patients that I've seen diagnosed with mild cognitive impairment or early dementia, where it really is hearing impairment as the major contributor. And once we address that, it's miraculous. They're able to socialize again.
Yep.
They're able to, listen to TV shows and stay engaged with their communities and do the activities. They've dropped out of book club, or they've dropped out of, the things they used to do and enjoy because of the hearing loss. And people just, they do these things without even fully realizing it, right? And I see it even happening amongst my own, cohort, because now I'm entering the AARP age group, and I see it happening amongst my own, friends, where one of my very best friends just told me last week, well, I've decided to get hearing aids because, quite frankly, I've been embarrassed at my book group. I'm missing like so much, and my children are complaining, right? Like I don't hear half the things they say to me. And so, all this social awkwardness starts to develop, right? Or you stop going to restaurants because you can't understand anything anyone is saying in a restaurant. And so that just sets up a cycle of getting socially isolated that is not healthy, right?
Absolutely.
Yeah.
Sharon, when we first chatted a couple of years ago, I was actually introduced to you by Victor Zhao, president of the National Academy of Medicine. You are involved in the NAMS Healthy Longevity initiative. Can you just, while we have you, can you just say a few words generally about broader? Obviously, you focus on an extremely important area in terms of brain aging, but you are immersed within these many parts of the healthcare system, and obviously healthy aging has been such an important topic in recent years. Could you just say a few words about your involvement with NAM and a little bit of what you see through your colleagues and other folks that you work with in the area of healthy aging and sort of what they refer to as health span improvements?
Absolutely. So, as you mentioned, under the leadership of Victor Zhao at the National Academy of Medicine, they've started a huge national and international, it's really global initiative to address healthy longevity, with the goal being, as you said, improvement of the health span. And so not necessarily per se just expanding lifespan. That is not the goal. It's really, the goal is so people can live healthy as long as possible. And so I am very aligned with this concept. And I just have to hand it to Victor and the National Academy, because when he got elected as president, he did a survey of all the membership of what were the most important issues for the membership. And healthy longevity was right at the top, aging and longevity, and was right at the top. Social determinants of health,
Yep.
right at the top, and then climate change, I think, was number 3. And Victor has just taken on these areas and these challenges full force. With regards to aging, I was on the planning committee for the Global Grand Challenge. And I also hosted the workshop on healthcare systems for that initiative in Singapore. And they have just come out with their global roadmap report for healthy longevity. In the past week, it was officially launched, and it can, if you search for Global Roadmap for Healthy Longevity, anybody can download the free report. And it is truly a masterwork, and I have to commend Dr. Linda Freed of the Columbia Mailman School of Public Health, where she's dean, and Dr. John Wong of Singapore, who were the co-chairs of this report. And they really focus in on areas that, need to be addressed globally to try to assure healthy longevity worldwide. And what I really liked about the report is that it takes a very sort of optimistic view of aging that I think is very well justified. And they really talk about, the older population being like an untapped resource for society. And I know you have focused in on this in other of your podcasts. And this is so unrecognized, how many billions of dollars the older population contributes to society, just on an economic basis, but also how much experience and volunteer hours and work hours that older adults are able to and want to contribute to society, right? And as we've discovered during COVID, we are all so interdependent, and the generations are interdependent on each other. And we really need to take better advantage of that and build systems that take advantage of that. And I think that was one of the really great visionary things of this report. And they talk about building workplaces and, educational systems, retraining and involving older adults, eliminating things like mandatory retirement that is still, it's less so in the US, but there are many countries where mandatory retirement is still in place. And I think allowing older adults to continue working and contributing, even on part-time bases, if they would like, making it possible for them to do so, creating social supports and social systems that really eliminate ageism and are more socially inclusive can only do us good. Having older adults volunteer in schools, for example, in areas where literacy is a huge problem, just having older adults come in to read to the younger generation, it's something that they love, and it's shown that it's good for their own health. And can you imagine what it would do for our kids? And then creating physical environments and cities that allow for healthy aging. And Singapore, I have to say, is on the cutting edge of developing intergenerational living situations where schools are contained within the same buildings where there's senior housing. And so the seniors can provide, help with after school care, right?
Right.
Even be surrogate grandparents, and then the younger generation to, bring life to the older communities, and shared gardens and shared playgrounds. It's just such an incredible concept. And then my area of interest being building healthcare systems,
Right.
that both robust public health systems and also community systems, and then hospitals and long-term care facilities that are all targeted to creating healthy longevity. And so this report is so important. I hope anyone who's interested in aging and in public health and in population aging globally will read it. And it's really a roadmap in the sense of it gives you the broad targets, and it's going to require individuals to step up and implement it in their communities, in their countries. And so I'm really hoping, and I've been planting the seed with all the leaders and with Victor, that it's so critical that we have next steps to this report that are building best case examples for how to roll it out and how to make it happen. So not just the global sort of roadmap that, it's, how you see those huge space maps, from a 20,000-foot view, but we need the map, like the Google map, the walking map that gets you step by step. We need that level of map now, not the 20,000 space view, of what the goals are to work for.
Absolutely.
But I think they did a really good job on that. The other part of the initiative that I should, besides the report, that is the brilliance of Victor Zhao and Tashi Yamada, who unfortunately is no longer with us. Tashi launched a global grand challenge, which was a series of pilot awards, and now hundreds of these have been awarded by the National Academy. And they were designed to seed projects around the world that were innovative and that would lead to healthy longevity. And there are so many really wonderful, interesting, incredibly innovative projects that have been launched now.
Yeah, I appreciate bringing that up, and I encourage everyone listening to go to the NAM report and look at what's being funded, and it really is quite diverse. And as you say, this sort of systems approach is definitely required. It's not about one drug or one device or anything like that, but getting everyone to the table to focus on this issue. Major call to action, but yeah.
Exactly.
Sharon, what else is coming up for you as we wrap up 2022 and head into 2023? Conferences that you're going to be presenting at, places, forums, so we can listen to you, potentially meet you. Anything else hot on the calendar that we should know about? Please take the floor.
Oh, thank you so much. So some of my next steps are, I just found out yesterday that I'm officially funded with multi-PI field velocities at University of Michigan with a $13 million PCORI grant.
Nice.
And this is a clinical trial where we are going to test our HELP program, Hospital Elder Life program, against a family augmented HELP program. So involving families in delirium prevention in the hospital, which is something I've always wanted to do, and Dr. Felicities is very interested in. And so we have just been funded with an 8-site clinical trial to do this with sites across the country. We're going to be enrolling 3,000 patients over the next 3.5 years. Nice. So we are so excited to work with PCORI and with a number of stakeholders and supporting groups to accomplish this. And so that is a huge area. I'm very interested in bringing families into the picture. We've realized, as you well know, during COVID, how important family involvement is in medical care. And as families were not allowed into the hospital setting, delirium rates skyrocketed, and in long-term care. And I think that was in large part because of the social isolation, the lack of family involvement, and then needing to substitute medications for that family involvement. And so it set off a cascade of events. So it's so important. And I know families contact me all the time, Ira. I must have 3 or 4 emails a week from family members around the world. I have just found your site on delirium, and what can I do as a family member? And so we've just launched a website called deliriumcentral.org that provides family members information about what to do about delirium. Yeah.
Gotcha.
So that is one big area of focus. I think the next big area of focus for me is an ongoing one on, combating ageism. And I think a lot of this, is through my educational efforts and through the National Academy's participation. But I think also, I am going to be joining the council at the National Institute on Aging.
Okay.
And I'm very interested in learning. They have huge efforts going on in combating ageism there. I want to learn more about what they're doing. I want to partner more with the American Geriatric Society and the Gerontologic Society of America to see what we can do there. The AARP, of course, has been a tremendous leader in this area. And I am already working avidly with Sarah Lenz-Locke there, who heads up their Global Brain Health Initiative in very, very important work. So that's another area that will remain of particular importance to me. You've asked about upcoming talks. I will be giving a neurology grand rounds for Harvard on February 15th. I can try to send you links. Would that be helpful?
Yeah. I'll put a bunch of. I'll put any links that you send to in the bio of the show. I'll link to you normally. Through the websites and both have a couple different websites connected, I guess, with the Harvard and
I'm going to be the Chevis Smith Distinguished Lecturer in Houston, Texas on March 27th to 29th. So
excellent.
I imagine that will be a big talk. I'm not sure. But that's not a talk. Okay. I just was awarded the John Phillips Memorial Award, which is the highest honor of the American College of Physicians, which is such an honor. So it's the highest honor in internal medicine. It's like a who's who of internal medicine. And that will be awarded April 27th to 29th in San Diego at the American College of Physicians annual meeting. But there's no talk. I think I just go up to the stage.
Get a nice award. That's cool.
Get an award, right? So those are some of the upcoming events.
Okay, awesome.
Thank you.
So hopefully send me those links, and,
I will.
and I'll definitely put them in the bio of the show. Just as last time, just so impressive. And as I continue to follow you then and sort of root you on from a distance, again, and I reiterate that because it's just so impressive everything you're doing, Sharon, and your leadership in this area is second to none. So
thank you, Ira.
for everybody that is going to be listening to this episode of the show across the various podcast networks or watching on the YouTube channel. Again, you've been listening to the amazing Dr. Sharon Inouye, Director of the Aging Brain Center, the Hyndman Arthur Marcus Institute for Aging Research, Hebrew Senior Life, also Milton and Shirley F. Levy Family Chair and Professor of Medicine, Harvard Medical School. Sharon, again, thank you so much for taking the time out of your schedule to come talk to us. Obviously, thank you for everything you're doing. And as we say on our show, thanks for helping to create a better tomorrow for so many people via what you're doing. Really such an impressive story.
Thank you, Ira, so much.